into some of the operational areas. But over to you, Ashley.
Thanks, Caroline. Morning, Chair. Kia ora koutou katoa. So I will talk about the basic science, but actually its application and how the evidence on the basic science has evolved and how that's informed our response, changes in our response. So if we start first of all with the transmission of COVID-19, it's clear as the evidence has evolved that the role of aerosol transmission is playing much more of a role than was initially thought it would. So the primary means of transmission of the virus is still this droplet spread, effectively sneeze or cough. These are the larger droplets which contain the virus. That's where the role of masks is obviously important, and social distancing and hand hygiene. So still the major method of spread, but the role of aerosol transmission has become clearer. And I dare say New Zealand has contributed to the science around this, because both here and I guess Australia, our managed isolation quarantine facilities are a very controlled environment. And so our research both on, and it's been published on evidence of transmission in flight, and also our investigations of in MIQ infections here, the small number we have had here, as has Australia, has really shed light on the science around the importance in some settings of aerosol transmission. And that's had quite an impact then on our response. We already had IPC precautions, quite significant IPC precautions. If you think about our investigation into the Pullman Hotel, where we've taken a really thorough look off the back of that at the ventilation systems, as they have in Australia, and our managed isolation facilities made investments to strengthen the filtration of, so as to address that aerosolization issue. But also a really key change was that reducing movement outside of rooms and timing of when individuals may be in the same space outside of rooms, just because of that emerging evidence about the importance of aerosol transmission. Fomite transmission, so-called hard surfaces, and the role of hand washing still may play a role, but it seems to be much, much less significant than that airborne spread, either by droplet or aerosol. So I think that evidence has really played significantly into our approach in MIQ and the changes we've made recently. And I think Caroline and her team will talk a bit more about that. And what is also clear is that the particular risk factor for that risk factors for those aerosol transmission events are the 3 Cs. It was the Japanese that first identified this, wrote about this: closed, crowded, and close contact spaces. So if you can address all those things, then you're much less likely to get aerosol transmission, much less likely to be an issue outdoors, for example. Second question was around the variants. And interestingly, if we think about the situation in India, and let me start with that, we've had this big increase, well, having a big increase in cases coming from India, and you will be watching and seeing that the exponential growth in the epidemic curve there in India. Only recently has India started doing genetic sequencing, whole genome sequencing, and that's been quite quite edifying, but because it first of all shows, and we're seeing it here, most of the people coming here from India actually got the B117 variant, the one first identified in the UK. So this variant has clearly made its way. It's got some evolutionary advantage. It must be more transmissible. It's made its way around the globe very quickly. It's one of 3 variants of concern, and you'll be aware the other 2 are the P1 variant from originally identified in Brazil and causing a real problem there. We haven't seen that. I don't think we've seen any isolates of that yet in New Zealand. And the other is the one first identified in South Africa. So those are the 3 variants of concern. But reading about this just in the last day or 2, there are probably hundreds of thousands of mutations of the new mutations of this virus every day. And we see this here when we can use our whole genome sequencing to track between individuals. About 50% of the time, there is a base mutation in transmission from one individual to another. So you can imagine in this global pandemic, there are mutations happening in the hundreds of thousands every day, but not all of those then carry on to become new variants or indeed variants of concern. So we have seen the B117 variant in New Zealand. It's been where we've had these recent incursions. We've seen some very interesting things happening where we haven't seen that high degree of transmissibility that they've seen in other countries, which has been really quite interesting. And so that, again, I think we can add to the global evidence around this. The third issue is around pre-departure testing. Now, in the pre-departure testing, I think needs to be in the context of how our testing in managed isolation has evolved over the last year. We started, and it was a bit out there actually at the time, but with day 3 and day 12 testing. The intention being to find people who were either had arrived with or were early on in their infection, or who had a long incubation period, and hence the day 12 testing before people departed. We have, of course, added in day 01 testing, and we've seen this very big shift in when we are identifying infections in returnees. So over 50% of infections now we're picking up at the day 01 testing, another 20% or so at the day 3 testing. And virtually all of the tests after that are positive are contacts who are contacts of those cases we've identified. Whenever we get a day 12 positive test, we assume that it's in-facility transmission until proven otherwise, and most of them prove to be otherwise, the vast majority. But the important thing here is that we are investigating every single day 12 positive, or indeed any positive after day 7. Most of them are contacts of known cases. Some it's just a late presentation, a long incubation period, and we've had a small number of cases where it is suggestive of in-facility transmission, and that has directly informed, again, what our changes in our response, so thorough investigation. In terms of pre-departure testing, this has been, of course, of great interest, particularly around the role that it does or doesn't play in helping prevent infected people coming into New Zealand. I would just make 2 comments. First of all, we don't routinely collect data around, and it's hard to think about how you would collect data about whether someone's had a positive pre-departure test and therefore has chosen not to travel. But we have got some information from managed isolation quarantine. Suggests at least about 25 people since the 1st of January haven't travelled because either they had a positive pre-departure test or they had, in the time between making their bookings, they had developed COVID and they were recovering. There's a number of other people who had cancelled their voucher at late notice, but we're not able to say whether or not that was because they had returned a positive pre-departure test. The second comment I would make, and this is what lay directly around behind our advice around the response to the current situation in India, and that is, of course, a pre-departure test 2 or 3 days before someone travels does not guarantee they are not then infected. In fact, it doesn't guarantee that they're not infected at the time of the test, first of all, and it doesn't guarantee that they won't become infected. So it's just one measure in the suite of measures. But I think our testing right through that managed isolation process now, including pre-departure, but particularly the day 01 testing, anyone who is a close contact from a flight of someone who we identify at day 01 also gets an additional test at day 6 and 7. So for some people now, even if they never test positive, they may be in their MIQ journey having up to 4 swabs as well as their pre-departure test. So there is a significant role that testing is playing there. And I guess finally, just on saliva testing, again, a lot of interest in this. We know we have capacity to do this in New Zealand from some labs, but just a couple of quick comments there. It is still PCR testing, so it uses the same laboratory process, but the samples are a little more challenging to process. And in fact, a Melbourne study showed about 15% of the samples you couldn't actually get a result from, partly because some of the samples are quite thick, the sputum's quite thick and it needs dilution, and that then reduces the sensitivity of the test. We are looking at this, as you know. I think people will be aware it's already been offered on a voluntary basis, only been taken up by small numbers of staff in quarantine. But we have also gone out with a request for proposals to our private sector operators to see what capacity they might have to support our existing staff testing program in managed isolation. And what we want to do is look at the role that salivary testing might play alongside ongoing nasopharyngeal swabbing, and in the context, of course, of the ongoing vaccination program of our border workforce, and in particular those in managed isolation. So I'll finish my comments there and hand over back to Karen.
So Dr. Craig, you indicated you wanted further information around how we keep people safe and also the operation. So I might ask Megan Main to perhaps substitute with Sue. And Megan, as I said earlier, is a deputy to me at NB and looks after a lot of the care for returnees and travellers. So over to you, Megan.
Thank you, Chair. Good morning. So in your pack, you'll have a diagram that looks like that, and that's our customer journey. It's one of the early things we did when NB first got involved, to understand that end-to-end system that we're asking people to go through. Excuse me. And importantly, the customer journey, as you'll see, starts well before someone arrives in managed isolation. So before they come to New Zealand, we provide information via our website. We've got a contact centre where people can call or email. We've got instructional videos, and in particular, we want people to understand what we're going to ask of them while they're in managed isolation. We don't want people turning up at the airport, as they did early on, and saying, oh, I didn't know I had to go into managed isolation, I had plans. And so once they're in our care, and we talk about them as returnees, we're quite deliberate with the language. They're not guests of hotels, they're returnees to New Zealand, and that has obligations on how we look after them, but also how they behave during their stay. So once they've made it, going back, before they arrive, we've got our managed isolation allocation system, which is a key control for us. Not only does it enable people to match their travel date, their arrival date, with making sure there's space for them in MIQ, it also is the first chance for us to get good information about who's coming. It helps us to understand family groupings, if we've got young children, if we've got people with access needs, such as needing a wheelchair-friendly room, dietary requirements, any religious requirements. So we can actually start to plan for the people that are coming. And that's been really critical in making sure that we're ready for what comes over the border. Whilst not everyone comes with COVID, they do come with other needs that we need to be able to support during their stay. And increasingly, we're seeing people coming to New Zealand with a complex range of needs that we need to support. Our managed isolation facilities aren't hospitals, but we need to make sure we're able to provide that care. That brings us to their time in managed isolation. We take them from the international airport to one of our 32 facilities in 5 cities, and then really their journey starts. From the time the plane touches down, they do exactly 14 days, 360 or 370 odd hours with us. And as Dr. Bloomfield described, the key part of that is the testing regime. Really what MIQ is about really good infection prevention control practices and support for people's wellbeing. Importantly, also protecting our workers who are exposed to people who might have COVID. Important to note that we treat all of our facilities as if they're in alert level 4, and so we maintain alert level 4 standards at all times, and we assume that each returnee has COVID until the end of their stay, when they pass their final health checks and they're given the all clear to leave. The journey does continue once people depart MIQ. We send them off into the community with information about contact tracing, about what to do if they have symptoms. We have a fees regime that kicks in once people leave. And also, if there has been any incident in the facility, there's follow-up testing and isolation for people. So that's a quick overview
Great.
of managed isolation.
So we're nearly at time, so that's been really, really useful, and I think that's some of the questions that we had put through. We started slightly late, so maybe we've got 1 or 2 minutes just for the final recap, and then we'll open for questions.
I might perhaps just close out this section and get into the questions, because I'm sure that'll cover many of the issues that are in the letter anyway. I'll just summarise for a moment. So, as I indicated earlier, both the Ministry of Health and MB work very closely on looking at what science can do to inform us about how we should evolve and change the MIQ processes. And we do meet regularly. We have many fora in which we are exchanging information and sharing experiences. So MIQ has really grown into quite a significant logistical exercise. We're very fortunate to have professional workforce of our colleagues from Defence, and Brigadier Bliss oversees the actual operational facilities that are the MIQ facilities. The workforce, as I said earlier, has a number of agencies involved and a number of private sector partners. We also have had a number of learnings out of various incidents, like the Pullman, and Dr. Bloomfield talked about aerosol transmission as part of that. We also, of course, on Monday, I'll be looking forward to the Australian bubble at opening, and so we do have some consequent changes in terms of the demand and the availability of rooms as a consequence of that. I'll finalise my comments at that point,
Okay.
Chair.
Thank you very much.
And very
That's
happy
really
to take your questions.
Okay, so I've already had some pre-signal questions. So first Chris Bishop, then Tracy, then Simon, then David. Madam Chair, thank you. Okay, across to Chris.
Yeah, I have a long line of questions, and I think it's clear we're going to have to come back next week for the session, because we're now 25 minutes in, so I'll get straight into it. Can I ask around the most recent cases through the Grand Millennium? I've still got Brigadier Bliss here. You said on Monday that case B was tested on the 8th of April, but you didn't know when they were last tested before this, but it was not likely within the last 14 days, and that the testing history of case B is being further investigated. Do we now know when that last test was?
So what we have identified through the process, can you just change that? What we've identified through the case investigation process, which clearly helped lead through the contact tracing, is that there are some inconsistencies in the recording of when testing occurs. We don't have evidence that testing has been conducted from our systems on the frequency that we would prefer it to be, or as the order requires. The order requires employees and employers to adhere to the testing regime. And what we are in the process of doing now is verifying with the employer what their records are and what the employee's information is.
So just in relation to, because I asked about case B.
Yes.
So do you know when they were last tested?
So the test occurred on the 7th of April, and so that is the one where he tested positive.
Yeah, but before
prior to that, in the system that we have, the border testing worker system, which not all employers have all records in, it shows that he was last tested in November. Now, he's a relief worker, he's a backup worker for the security area, but we are in a process, as I said earlier, of verifying. That's what our information is showing. What we need to understand is what the employer and employee's information is.
Thank you for that answer. I just want to be very clear. So this person was meant to be tested fortnightly or weekly?
Fortnightly.
Fortnightly. So they were last tested on the 8th of April, and prior to that, the last test that you have a record of was from November last year.
That's what our information is showing. What we're in the process of doing now.
That's a 6-month gap.
What we're in the process of doing now is verifying with the employer what their records are.
Okay, so
just got a supplementary across here.
Supplementary, that just going back a step. Hang on, just going back a step, because you made it very clear that he was a backup worker. So my understanding is that it's not inconceivable, it's not unusual that sometimes people are only working very periodically. So
surely they can
is that part of that process in finding out how long he's been?
That is right. I would say he's a regular relief worker from what we understand from our system.
So the follow-up is, are regular relief workers or backup workers like this person, are they still required to obtain weekly tests?
Fortnightly.
Sorry, I meant to say fortnightly.
Yes.
So they are. Okay.
Yes.
Why? I suppose the obvious question is, why was it not picked up earlier that this person wasn't being tested between November and April this year?
As I indicated, Mr. Bishop, we are currently looking at what information the employer holds. We have information that we can see in our systems, but we know the employer also has some manual records, and we're verifying what the situation is between the employee's information that's being provided and the employer records, and reconciling it back or triangulating it back to our...
Do you know how many hours this person has been working in the facility without being tested?
No, I don't offhand, but as I said, he is a relief night shift worker, and he looks to us, from what we know from our systems, to be more of a regular relief worker. So perhaps not quite full time, but not what I would differentiate that from a casual worker, for example.
Okay. How many employers don't use? So I understand there's essentially a voluntary register administered by the ministry, right?
Yes.
How many employers don't use that register?
So I think there's, correct me if I'm wrong here, 589 employers across the border, and 340 borders, Andy,
So my understanding, all of MIQ employers use BWTR.
of which there are
Of which there are approximately 300.
about 300 employers. in
300 out of 589 use it.
Yeah, well, I think the issue is it's not yet mandatory, although that is one of the things that Ashley and I have been working on, to say that it needs to be mandatory.
Okay, so 300 out of 589. Do you know what the quantum of full-time equivalent employees the 300 represents? Just trying to get a sense of how many employees would not be covered.
It would be around 4,000, because that's the number that we have in managed isolation.
Sort of supplementary costs
using
here.
So just to be clear, this is the border worker testing register that has been voluntary. The 300 is the number of employers across all the managed isolation facilities. So all the employers who have people working in managed isolation also put data, their people, into the border worker testing register. Every employer is required to hold their own register or use the border worker testing register. So it's not that those not using the WTR haven't got a record, and they are required under the order to keep a record. It's just not all have been required, and not all have availed themselves of the border worker testing register.
Just got a supplementary across here, sorry.
So it's in a similar line of thinking. So we're just talking about, people, there's a high turnover because some people are working part-time or as backups. So now that you've vaccinated the MIQ workers, the frontline workers, and there is a changeover, what are you doing to ensure that the next backup people are also vaccinated? Is there a system in place?
Yes, so just to give an update on vaccinated numbers at the border. So as at last night, 89% of MIQ border work. Actually, I should focus just on MIQ workers, because the border worker population is a much larger cohort involving airlines and such like. So the MIQ workers, the 4,000 approximate workers, then we are sitting at 89% of those are vaccinated. We know a further 3% have bookings for vaccinations. As of the 1st of May, when we will be absolutely mandatory, you may not work in a managed isolation facility unless you have proof of vaccination.
So I've just got a number of questions pending. So just over to Tracy and then across to Simon.
Thank you. You said, just to sum up most specifically, that it's been a year since the managed isolation became mandatory for travellers, and mentioned the fact that it's become what I think we could all agree was a massive logistical kind of exercise. So I'm interested in what sort of major developments you've had over that period that have become probably just business as usual now, and what sort of major developments you see are going to be the next challenges as we continue along this sort of continual improvement process.
So I mean, some of the challenges initially were around security, and a very deliberate decision by the government early on was to use hotel facilities as isolation places of isolation for people. They are not they're not prisons. They were designed as hotels, and so we've had a lot of work that we have done to improve CCTV, for example. We've had a lot of work done on perimeter security. We've certainly had inconsistency of service provision across security companies, and we have reduced the number of security companies involved from 18 to 3, and by the third quarter of this year we will be reducing that down to 1 private security company that we use, in addition to give a bit of flex across the system to the defence workforce that we have on site. I mean, the biggest things that have impacted, I guess, through that period are the evolution of the science, and that's where it's been really important to work closely with our colleagues at Health. We've had the benefit of technical advisory and clinical support for those areas. I think, you know, it's a big system with, as we said earlier, over 130,000 returnees coming back. And each of those returnees have had different situations they were coming from. I think one of the big challenges is that demand has exceeded supply of rooms at many points. That is not the case at the moment. But Jim, I think you can probably highlight some of the things from your...
Yeah, thank you, Carolyn, and thank you for the opportunity. It's as Carolyn said early on, it was about security, and then the evolution of science has been come around transmission, and for us in particular, it's about in-facility transmission. And I think the Pullman review in February highlighted to us, this is a new thing we had to look at. So post the Pullman review, a number of operational decisions were taken to immediately enhance the safety of the returnees and the staff, and that included the implementation of movement controls to reduce any non-essential movement throughout the facility, to try and remove that incidental potential of contact between returnees. There's been a ventilation review to look at the, I suppose, how fit for purpose the extent ventilation systems in them with each of the facilities are, and where we've been able to increase ventilation by the use of HEPA filters and purifiers, especially in hallways and lifts, to reduce that risk and allow us to continue to operate. And so the Pullman's a good example where we actually shut the Pullman for a short period of time, no returnees, conducted a detailed on-site assessment with engineers and the like, and then we're able to reuse part of the Pullman whilst ventilation work was done in stacks. And so we could we could conduct the repairs and upgrades on the centre stack, which is the lift area, then occupy one side of the stack, which is the rooms, whilst conducting upgrades on the other side. And it's been a success so far, and the Pullman should be up to full capacity ahead of time on the 22nd of April. And we'll continue that series of ventilation reviews for the next 2 months as we can get into facilities during their scheduled maintenance, or as we manage our operational flow of returnees to allow those on-site inspections to be conducted. So, that's been a big learning evolution for us, but I think also an example of how we've had to be agile and change to the new circumstances or situations that face us.
So is there any big things that you can foresee over the next sort of 6 months that would culminate in another sort of evolution of that, or?
Probably cohorting.
Yeah, so, excuse me, we looked at cohorting earlier in the year, and for cohorting for some facilities is quite easy to do given the size of the facilities or the number of flights that they can physically receive. In a larger facility, it becomes a bit more difficult. I mean, demand is high. Achieving a cohort over a 14-day isolation period is very hard to do and maintain capacity high. These are not individual room, individual night bookings. So we have managed to achieve some cohorting through physical layout of facilities and then also through time. And so we do try and use a 96-hour cohort in some of our facilities. That allows us to keep those that have just come into the facility the first 96 hours, physically and by time separate from those that may be leaving the facility at the end of their isolation period. And by doing that, we can also then manage their exercise time or their access to smoking areas and the like based on the cohort that they currently sit in that 96 hours. So looking forward with with questions around capacity, what do we do with the capacity with the safe travel zone with Australia? We have options to look at cohorting again, and can we use that capacity to achieve a greater cohort effect?
Thanks, Chris. To David Seymour and then Chris Bishop.
Oh, yes, thank you, Madam Chair, and thank you for coming along. This is probably a question for Ashley. I'm just interested in the Australian cases. We understand there's been 3 in the last year that originated from Australia that have come into MIQ. One in August, one in November, and one in January. I'm interested in how much more we know about those. Did they originate from hotspots, Commonwealth hotspots that were identified at the time? The reason I ask this is that it would be very useful to know if we have the ability to identify if cases have come from hotspots in case there's a hotspot in the future when we have an open bubble.
Thanks. And are you meaning hotspots in Australia or beyond?
Well, Commonwealth hotspots. So that's their definition for
under there. Yeah. So we did do a look at each of those cases and found that really they didn't present a risk here to New Zealand, and the fact that they hadn't come from known, hotspots in Australia, including, for example, Victoria, which had the big outbreak in the middle of last year. So one in particular seemed to be transmission from an aircrew member who had come in from another place into Australia, and there seemed to be transmission at some point in the journey. There was obviously, we picked that case up here. What I would say is, as we go into the quarantine-free travel arrangements, our exchange of information with our Australian colleagues now is very frequent and smooth, and so our situation reports and their situation reports have an update every day on what's happening in each other's countries. So it would be very easy for us. So as soon as we had, for example, our case B, who we identified last Thursday, one of the first things we do is notify our Australian counterparts, and of course we're providing information to them.
Okay, so just to be clear, there's 3 of these Australian cases. None of them came, you know that none of them came from known declared Australian hotspots at the time. One of them came from somebody who got it from aircrew who had travelled into Australia from elsewhere.
That's my recollection, yes.
Do we know where the other 2 came from? Because I think this matters because pretty soon people are going to be able to come, those 3 people would be able to come into New Zealand and we wouldn't be able to know where they've come from. So what's the plan?
Now we did have a close look at this a couple of weeks ago, and I'm sorry I haven't got the information just in my head, but I'm very happy to provide a summary of each of those cases and what we know about it, so we can send that through.
Well, that'd be fabulous.
That'd be helpful.
And can I ask, secondly, you said that saliva as a medium, the Ministry of Health is still not persuaded that it's reliable. You mentioned that perhaps 15% of cases at the lab, they're simply not able to use the medium. I spoke last month with Dr. Anne Wiley. She's a Kiwi at Yale who 10 years ago decided to specialise in saliva as a medium for testing, which didn't seem like a very useful thing at the time, but recently she's become very busy. In her view, saliva as a medium is perfectly adequate, in fact, as good, if not better, than nasopharyngeal material. She does question whether laboratories in New Zealand are up to it. You're telling us that the Ministry of Health's position is that actually there's a big gap between saliva and nasopharyngeal. Is she wrong, or how do we explain that?
So, just to clarify my comments then, actually the evidence, and we've had a look at this, it's very important, is saliva testing, if it's validated, can be as sensitive as nasopharyngeal, remembering that both are PCR-based tests. The issue is that there is a different and somewhat more complex process actually of collecting and processing a salivary sample. And in the study I quoted from Melbourne was they found around 15% of the samples they couldn't process because you just need to go back and get another sample. But that's not a reflection on our view of whether the test itself is sensitive. And that's why we've in fact done the request for proposals, and we got proposals back, and we're looking at the role that salivary testing might play, particularly for our border workforce, complementing ongoing nasopharyngeal testing. And of course, the real interest here is it's less invasive, but it does involve setting up a new collection process and a new processing arrangement in the lab. So there is some complexity.
So I'm getting reports of people that have had 100 nasopharyngeal swabs, people whose sinuses are actually collapsing, people bleeding. And of course, people are going to be reluctant to get tested as a result of this. So is there a time frame for when we might be able to resolve some of these challenges around collecting and processing saliva samples?
What I would say is I think the group that's probably the most affected by regular sampling are aircrew flying internationally, because they've got testing requirements going into some countries and then coming back. And so we do have an arrangement with Air New Zealand whereby those crew, first of all, we were allowing every second swab to be a throat rather than a nasopharyngeal, but they are now actually using salivary testing as well for some of those crew. So you could say in that sense, it's already underway for the group that, and it's not so much their sinus collapsing, but it's just, essentially you get a raw area on the back of the nasopharynx from repeated swabbing.
That's how they described it.
Not so pleasant.
Okay, sorry, Madam Chair, can I ask just one more question? It's unrelated, or to that one anyway. Just so far as the charging for MIQ, I mean, there's been some criticism that they're effectively operating an honesty box type system. When I book a flight, if I told Air New Zealand I wanted to pay later, I don't think they'd let me on. What is the problem with pre-charging and perhaps having a system where, much in the same way as in some countries you can collect your sales tax on the way out, you could collect your, you would collect the fee, and if people stay for 90 days, you could reimburse them. And I just put the question a bit more specific. Did you advise that be the system? If so, what was the ministerial justification for refusing your advice? And do you have any work to change the way that payment is collected underway at the moment?
So thank you for the question, and I might ask Megan just to come back. There's a little bit of a split between the responsibilities between MB and Defence and the facilities, and Megan does have a good understanding of the invoicing. So the invoicing system from recollection came in November?
In August.
August last year. It was set up pretty quickly, and there was a concern that was expressed early on about if we started to charge, would that disincent or create a barrier for New Zealanders returning? That was why we settled on a 90-day period as a reasonable period of time that you would be able to reside in New Zealand. But if you left within that period, you would have to pay managed isolation fees. Actually, the collection of that, I think from memory, we've got about 26 million that's been collected through that process so far. We have recently moved some of the administration of that from within the MIQ system, where it was essentially a manual-based process, into MB's finance area to put it into a more systemic, better, streamlined process than it was. It was a bit clunky, I'd have to say that. The second thing that I would just add before I hand over to Megan to talk specifically in respect of those questions you raised is that the fee collection process has been improved by some recent data information sharing processes that have been put in place, which mean that we are much clearer about whether people have resided and permanently in New Zealand or whether they return.
So just to be clear, people who think they might swerve away from paying the MIQ fee, you are now matching when they enter and leave the country with Immigration New
Yes,
Zealand.
that's correct. Yeah.
Okay.
Not necessarily.
I'm sure people will be pleased to know that.
Yeah, not necessarily Immigration New Zealand, which
Customs?
has details for
With
non-New
customs?
Zealanders, but actually with both. But the non-New Zealander percentage is about a quarter, I think, from memory. But Megan, do you just want to specifically answer the issues about what we thought in terms of initial collection processes?
Thanks, Carolyn. I don't remember the exact advice we put up around duration for people to pay, but it was certainly based on a concern. And if you think back to August, it was quite a bit, even a different time to where we're at today in terms of the group of people who were trying to get back to New Zealand. And so there was a strong desire to not make it harder for New Zealanders to come home. In the case of critical workers and groups of workers, we've got a different fees regime. We do invoice them up front and they have 30 days to pay. So we do have a nuanced system. I'd say it is quite a layered system at the moment, where we've originally, the intention was to make it a fair contribution to the cost of a stay for people other than New Zealand citizens and permanent residents returning home. Over time, that's evolved. And we're now looking at some things we can do to streamline the system. But overall, our focus has been on making sure we invoice the right people, the right amount. What it means is we have to match a lot of data. We have to know who's in a room. So the current fee regime is based on a room and the number of people in that room. So we need information from DHB's Ministry of Health around the room configurations in facilities, because as it happens, the Ministry of Health runs the National Border Register, information from Customs, information from Immigration, and our own information that we now collect through the Managed Isolation Allocation System. So it's quite a coming together.
Just to supplement, a common theme with the testing that Chris Bishop referred to and the vaccination, where you kind of, with respect, assembled over whether we were talking about MIQ workers or border workers,
Yes.
and the vaccination rollout generally seems to be a problem with information systems. We simply don't have one true record or database of who's up to what where. And so it always seems to be challenging to know who's been tested, who's been vaccinated. Are you frustrated, or do you feel that you need perhaps more funding or a different approach to information systems throughout the response?
So I think information generally has been at times a challenge on particular issues. With the border testing worker register in particular, there's been further updates. So the system was put in probably a little bit like the MES system was put in for booking rooms as a minimum value proposition. And it was functional, but there was always an intention to continue to involve, invest and update in it. And we've seen a number of updates in the border testing register to date. There is a substantial rollout of an update next week, which will provide a lot more functionality. And actually, my understanding is that will give us not both, it will give us both in one register, whether the person has been vaccinated and the testing data.
Yeah, just a quick comment there. The challenge hasn't been recording who's been tested if they are in the border worker testing register, because we can link it by NHI to the lab results. Likewise, it's not a challenge to record, to understand who's been vaccinated, but because we've got a very good COVID immunisation register. The challenge is the denominator. And for over 500 employers, many of them private sector, and of course employees rotating through quite often. And so it's getting that denominator. As Carolyn said, next week as well, we will be able to link up the fact of vaccination in the COVID-19 immunisation register with the border worker testing register. So employers will be able to look and find out both the testing status and the vaccination status.
So the real problem is that the people you're contracting don't register their workers, so you don't No, so they're not in the core of your registration.
It's a really dynamic system in terms of how the workforce comes together, and really it's the denominator, as Ashley was talking about, does change. So we have quite large changeovers of defence personnel, for example, who spend a period of time in different functions in MIQ, and then they leave and a new cohort comes in. And so it's not a static kind of set of employees that are working in the area. And of course, that becomes a little more complicated the further away we get from the government agencies. I mean, government agencies, I have a reasonably strong...
With respect, I think you've answered my question.
You've had twice as much time as I have.
Wait a minute, one moment. Okay, so we're nearly at time, and thank you for your responses. What I might just do is, because we are nearly at time, just hand over very quickly for one final question to Chris Bishop. Did you want to just close off?
No, I think Chris has been waiting very patiently, but can I just say I think Chris will be interested too. Dr. Bloomfield undertook to provide details to the committee of the 3 Australian cases in August, November and January, and I wonder if the committee might like to resolve to request that Dr. Bloomfield provide that, because I think there's a lot of interest.
So what will happen is that we'll, once the hearing is finished, we'll move into closed session. But at the moment, I think if we can just, while we've got the team here,
we're going to have to
hand over to one.
We're going to have to come back next
one
week,
final question.
Do you know how many workers have missed tests that they should have had in the border workforce?
No, I think will be. Is it no?
No, we don't know the exact number. We're moving towards one mandated system. Next week, from MBIE's point of view, looking over the 300 or so employers in MIQ, we'll have the ability to report on percentages of compliance and non-compliance in a much more robust way. We ran a report. So the border worker testing register and a system we implemented as well to capture attendance on site electronically, who's on location, have been in place since February, and they've both been improved as we've understood how we can make them work better. But we ran a report in late February and found duplicate entries where, for example, someone might work in 2 different facilities over a period of time and they were in as 2 people. So there's been a raft of activities going on to clean that up, to get to a point where we can get meaningful click of the button reporting, which will come next week with the upgrade to the latest upgrade to the border worker testing register.
I've just got one quick step. I haven't asked any questions, so I'll go quickly. I'm interested to know, when you look internationally and you see, I've signalled, I haven't asked one question.
So just, can we just, I'll share this. Okay, I think we are at time.
Can I have one quick step?
It's on that
point.
And then we will close.
So when you look overseas and you've got instances where you've got a whole stadium with people that are coming in and getting vaccinated, and there seems to be a lot of discussion in New Zealand in comparison to looking at the percentage of the border and a great focus on that area of a risk area at the border. Can you explain to me the benefits of just other countries that appear to be just rolling it out across versus a lot of detail?
Can we just leave this?
No, because the point you're getting onto is the detail of who's on a register and who's not. So what I want to understand that why are we doing that as a country? What's the benefits of doing that?
Very quick response then. It's quite clear that the highest risk people from infection are those working in our MIQ facilities. So hence our focus has been very much on vaccinating the border workforce first. As we roll the vaccine out to the wider population, there will be a whole range of other ways that people can be vaccinated, including large-scale events. We have already started planning for those.
Okay, thank you.
Well, thank you very much.
I never got an actual sub on my question. I asked one question and then I'd like to ask a follow-up. Can I please have that? Because we've had literally a 50-minute session, 20-minute lecture.
That was what was agreed by the committee in advance.
I know that, but who do you think has the numbers on the committee, Madam Chair? Well, wasn't agreed by us.
I think it was a discussion. I think what we're going to do now is move to close this session, and thank you very much for that time.
I'm going to have one more.
Madam Chair, can I just suggest, I know Chris Bishop works extremely hard on this topic. He does usually ask some very elucidating questions, and the point of the committee is to get information from the executive on behalf of Parliament. I think to not use the remaining 5 minutes, so it's for Chris to be able to ask a question would be a great shame.
But I think the session was for 50 minutes. By leave of the committee, are we able to have?
Madam
Yeah,
Chair,
I'm happy to leave them with
Okay,
one.
by
You
leave
can
of
have one,
committee,
yeah.
just one.
Give them one.
One further stuff. Okay, thank you for your indulgence. We've learned that case C in the Millennium case cluster was a security guard. In August last year, it was announced that the Defence Force will be providing support to decrease the reliance on private firms, and that the government through MB will directly employ security guards and other staff. How many security staff are still being contracted by external security providers and working in MIQ facilities?
So if I can just give it a little bit of background, as I said earlier in the session, initially we had some 18 security companies that were involved. That's now at 3, and in the third quarter of this year it will reduce to 1. That having one private security company does give us a bit of flex if we need that in the system. When we look at the number of security guards we have directly employed, we have been through quite an extensive recruitment process for that. As of Monday this week, we have 30 security operations managers who are now working in 30 of the 32 MIFs. There are 2 further to confirm. We have started the employment of the direct security workforce into MB. We're doing some of that linked with MSD to look at how we can identify people who are looking for work who would be suitable to be trained as security workers. And I think Wellington is the first roller out of that, because we only have 2 MIQ facilities in Wellington. The numbers are relatively small, I think about 16. But we also, at the time, we had the issues last year with security guards. We did ask Defence for a greater representation of their personnel to offset some of the exposure to risk that we are now starting to close out. We had, of course, our funding confirmed in December as well, and that meant that we were then able to go ahead and start the recruitment processes. But you'll understand it's both recruitment and training of those folk. And I'll just add for clarity too, any of those personnel who are coming into work will be fully vaccinated before they start work.
Thank you for that.
Okay.
Madam Chair, I want to move a motion.
We can do that in closed session. So thank you very much for that.
It's relating to the...
Oh, okay.
Yeah, well, I'd like to move that the session be extended for a further hour.
Just for now.
I know, I think we can move into closed session, and I think we'd like to...
Well, no, I'd like to move the motion. What the motion?
The motion...
motion is that the session be extended for a further hour to question the officials in relation to the briefing.
Well, we haven't had that in terms of notice, so what I would like to do is...
I'm just moved to orally.
I think it's the chair's discretion.
Yeah, I think we close the session because we've actually designated some extra submitters to the petitions. Normally the motion would be, I mean, we can vote.
I'm happy to write it down for you if you like.
Okay, what I suggest is that we move to closed session, and in the meantime, I would like to thank the submitters.
I moved the motion. Yes. I'm moving a motion before the committee. You are required to put that to a vote.
I will just get some procedural advice, and I'd like to move that we move to closed session, and we can take that discussion in closed session. So thank you very much for...
But I don't think we've had a response to the motion, have we?
Well, I'm proposing that we move into closed session to consider.
Yeah.
So you're just going to close the session.
I'm proposing that...
What if the motion passes and the officials will leave?
Then the officials can wait outside and we will make a decision and then let you know.
We're happy to wait outside.
So, thank you very much.
Thank you.